Hello and welcome back. In this video, we're going to cover three letters at once: the S for shape, the second S for size, and the I for internal structure. Now, none of these are quite as foundational as location or borders, but each does give you useful information. So let's start with size. Most of the time you cover size when you describe a location, saying something like it extends from the canine to the first molar. So that gives a sense of size, or you can give an actual measurement. So let me talk about three different places where size actually changes your differential. First, dentigerous cyst versus just a hyperplastic dental follicle. The follicular space around an impacted tooth is normally just a couple of millimeters. If it gets larger than 5 millimeters, then you should start thinking about a dentigerous cyst. Second, the nasopalatine duct versus the nasopalatine duct cyst. Now, normal nasopalatine foramen is up to about 6 millimeters, and I've seen bigger than that without it actually being a cyst. But once it really starts getting, I'll say, around a centimeter or even larger, specifically with cystic features, if it's starting to push teeth around, obviously, then you start thinking of a nasopalatine duct cyst. Third, osteoid osteoma versus osteoblastoma. So they're the same lesion histologically. The cutoff is just 1.5 centimeters, so 15 millimeters. If it's smaller than 15 millimeters, then it's an osteoid osteoma. Larger than that, osteoblastoma. So these are rules of thumb, not absolute, but it is worth knowing. The other size point, certain lesions tend to be very large. So things like this, where you see really large growing lesions, they tend to be large and benign. So ameloblastoma, ossifying fibroma, those are the big ones. So you see something like this, you start thinking of those. All right, and what about shape? Well, several synonyms here: circular, round, ovoid, hydraulic, cystic. These are all descriptions of things with smooth borders that are round and curve continuously. Hydraulic and cystic are even more descriptive, more specific. When you see a lesion that looks like a water balloon, where the border kind of bulges out and adapts to whatever surrounding structure it touches, that's hydraulic. The example here is a dentigerous cyst. And so this is what I'm talking about. When I see something, maybe it's in the maxillary sinus and it just conforms to the sinus floor, you might start describing that as cystic or hydraulic. It's a strong indicator of cyst, although benign tumors can occasionally appear similar. And so thought question for you: a lesion is very round and sac-like. Is it more likely benign or aggressive? Hopefully you're already thinking benign, round, sac-like, hydraulic. All of those are signs of a slow, fluid-filled, well-contained growth. Aggressive lesions don't have time to look like water balloons. All right, so scalloping, what do we mean by scalloping? That's a very specific shape. When the borders of a lesion, they're usually smooth and well-defined, but you have multiple arches like this. A common location to see scalloping is between the roots of teeth. And so when you see that scalloping between roots of teeth, think one of two things: either a donogenic keratocyst or a traumatic bone cyst, or sometimes called a simple bone cyst. We'll cover the differences between those when we get to those lectures, but know that OKC also tends to scallop around the borders of the mandible. And so what do we mean by irregular? So irregular can kind of be thought of as a catch-all. When a shape doesn't really fit the definition of round or scalloping, when the borders kind of jut out in different areas like you see in these cases, it's still well-defined, but it has kind of a irregular pattern to it. In this case, it follows the trabecular pattern. So both of these are likely dense bone islands or idiopathic osteosclerosis. And they are very benign. Sometimes irregular gets you thinking of malignancy, but in some cases, irregular is more of a benign thing. If it's moth-eaten, if it's radiolucent and kind of invasive into bone and has that irregular pattern, then we're starting to think about malignancy. And that description belongs in more the border than the shape. All right, now on to the I of our lesions acronym, the internal structure. So the basic question is it radiolucent? Is it radiopaque? If it's kind of a mix of both, then it's a mixed lesion. And so radiolucent means dark, less dense than normal bone. Radiopaque means it's lighter or more dense. Mixed means it's both, and that's where it really gets interesting. With a mixed lesion, we have a bunch of different patterns: abnormal trabecular pattern, internal septation, dystrophic calcification, amorphous bone, and tooth structure. So let me walk through each of these. When the trabecular pattern is altered, you can describe it more specifically. Common patterns are going to be orange peel. See where it looks like small little pits of an orange? It's an increased number of trabeculation, but very fine. And that's maybe a less common, but one of the presentations of fibrous dysplasia. Or there's the ground glass, kind of a salt and pepper. I may describe this as granular appearance. The trabeculae getting even smaller, space is getting smaller between the trabeculation, and the bone almost looks textured. So this is classic and the more common appearance of fibrous dysplasia. So I have an acronym that covers ground glass lesions, and that's HOOF. We'll talk more about that when I get to the descriptor specific day later in the course. And you can also have increase in thickness, increase in density of the trabeculation. And that's what we're seeing going on here. We've shown you this before, and this is just a periapical inflammatory lesion with surrounding sclerotic bone. But that's what's happening in that sclerotic bone. Those trabeculation are getting thicker and more densely packed. That's what causes it to look more radiopaque. All right, what about when you see internal septation? That's when you see these little loculations, and then the septation are the areas of bone that are dividing those loculations apart. So we call this lesion multilocular, that appearance when you have all these different loculations. So they can be curved or straight, they can be coarse or fine. You can see this one has really fine trabeculation, whereas this one are more coarse, more stark and well-defined. And this is what we describe as somewhat wispy trabeculation. This one you could describe as wispy when it's really fine. And this one has very specifically straight loculations, straight septations. So important point here, don't confuse multilocular with multifocal. Multifocal means distinct lesions in different parts of the jaw. Multilocular is all one lesion. Each of these is just one specific lesion that we can see in these images, but it has these different compartments, so these different internal components. Multilocular is typically a sign of benign tumor. We'll cover these in our MACHO seminar. MACHO is the acronym that I have for the differentials that you include when you see a multilocular lesion. And so we'll cover those later. The patterns are typically, we would call this soap bubble, when it actually looks like soap bubbles, very round loculations, different sizes. And so that's a great descriptive term. And Ameloblastoma is the one you should think when you see that soap bubble appearance. When you see these wispy, faint septation, particularly in the mandible anterior to the first molar, that a lot of times is descriptive for central giant cell granuloma. When you see these straight septations, where you have kind of these angulations of the compartments, then that's what we call tennis racket pattern or straight septation, and that's more specific for odontogenic myxoma. But again, for this lecture, just worry about description, and you'll see how if you can get an accurate description, it really leads you in some cases to a very accurate diagnosis. And just be aware as well, any lesion that you have, benign, malignant, if it's there for a long term, then these dystrophic calcifications can form. That happens in damaged soft tissue. Lymph nodes that have been chronically inflamed, cysts that have been sitting around for years. This example is a long-standing residual cyst where it's developed these delicate particulate calcifications internally. So just remember, any long-standing lesion can do that. This was the example of lymph node calcification. We'll cover different soft tissue calcifications when we get that lecture. So any long-standing lesion can develop these. It doesn't necessarily change your differential, but it's worth knowing and describing. All right, another thought question for you. You have a very ill-defined, invasive, eroding lesion. It's been eroding the surrounding cortical bone. Is that likely to be benign or malignant or aggressive? Yeah, aggressive, probably malignant. In this case, there's no sclerotic reaction. There's no bone formation. So I'm going with malignant until proven otherwise. And so that covers our size, our shape, and internal structure. And then the last part, we're going to cover the O of lesions, other category. And that's the effect on surrounding structures. It's the letter experienced dentists most often forget. And so then we'll put it all together with a Mad Lib, if you remember what those are. See you on the next one. Thanks a lot.